And if you push me, if I had to define what a purposeful admission is, I'd probably say that the patient knows why they're coming in, and so do the TATs, to the team they're looking for, that are looking after them, I should say. So everybody knows why the patients come in. You've probably got discharge criteria set. So if somebody's, I don't know, if somebody's doing a lot of drugs and they're suicidal and there's a possibility of an underlying mental illness, your discharge criteria would be to assess the extent to which the self-harm is evidence of genuine suicidal intent. You'd assess whether there is an underlying mental illness, and you'd probably take a very brief look at the substance use, although frankly I think managing primary diagnosis of substance use in an acute ward would be a big mistake, but that probably would be discharge criteria number 3, that you'd have looked at that. When you've done that work, you know, that patient should reasonably be able to go home, unless there's something there that needs further treatment. It seems to me it's not beyond the wit of man, or woman for that matter, to say that job of work is probably going to take 2 or 3 weeks. So today's whatever it is, the 2nd of October, I expect, give it a week's slippage, I expect that this patient will be discharged by the end of October. Right then. So you've got admission criteria, discharge criteria, you have an idea of what your treatment plan is, and you've got a discharge date. Immediately what happens then is that you keep your community nurses engaged. You can book in appointments with your critical people for the next 4 weeks, whether that's with junior doctors, consultants, key workers, community nurses and other community resources. You can actually negotiate a plan of work with the relatives or carers where that's necessary, and you've got what I would call a purposeful engagement, and you've got an engagement which is likely to be a very good job of mental health practice and which is actually going to be very time limited. The alternative, unfortunately, I think is usually much more common. People come into hospital, they're not sure what they're doing here, they're not sure why they're here, what needs to change, or indeed what they need to do to get out. And some people will then play the game. They'll take their tablets and they'll say, yes, everything's fine, doctor, and they'll go home. And others will be hard-pressed to get them out of the hospital within 60 days, 90 days, or even longer. I don't think I've yet been on an acute ward where they haven't had some patients that haven't been there for upwards of 6 months. I really don't think I've ever been on a ward where there hasn't been 1 or 2 patients of that nature.